If you think about it, there are two very sacred things that happen in our life. There's birth and there's death. Everybody has them. No matter what religion you are, no matter what socioeconomic level you are, everybody's going to have a birth and everybody's going to have a death. Think about all the things we do to prepare for a birth. The room, the name, the clothes, the furniture, the planning, the birthing process, reading books. We do so many things to prepare for a birth. But what do we do to prepare for a death? We don't talk to our families about it. Even when people are diagnosed with a terminal diagnosis and they're close to death, people don't want to talk about it. And there's just so many gifts that you can give to your family, to leave your family with. And if you don't talk about it until the end, then you're not really going to be able to leave those legacies that you want to live. And people aren't going to be able to say, I'm sorry, or I forgive you, or you're not going to be able to say, I love you, I forgive you, because you just put it off, put it off, put it off, and then before you know it, you're too sick to do all those things that you want to do.
Wow. Fran, that's totally right. So what you're saying is that some people retreat into themselves or withdraw their ties to the family, their loved ones, whatever, until it's too late. So we have here end-of-life situation where people aren't preparing, or some people are preparing. What are some of the things that are out there to help people prepare or have the appropriate type of care, such as hospice or palliative care? We mentioned that you are involved with that, Fran. Is there a difference here, and what is the difference between hospice and palliative care?
Well, I think that's another big misconception. Many people really, if you ask 10 people on the street what palliative care was, I think you would get 10 different definitions, and probably everybody would have a little piece of the correct answer, but nobody would have the actual correct answer. Palliative care is a philosophy of care that can occur at any time during the disease. You're diagnosed with cancer. You have pain. We do palliative care to manage your symptoms. One of the key things of palliative care is symptom management, whatever those symptoms are, whether it's pain, whether it's shortness of breath, whether it's anxiety, depression, constipation, diarrhea. Whatever your symptoms are, palliative care looks at symptom management. The second thing that it does is we look at the family as a unit of care. We're not just treating a patient, we're treating the family. How is this illness impacting the wife, the teenage children that are trying to go to high school with a mother who's dying at home? What is happening to the family unit, and how do we address that? It's all about communication. You know, we all know that navigating the healthcare system is difficult. You've got all these different specialists taking care of you, and very often there's not one person that comes together and say, okay, what's happening here? What did he say? What did she say? What does this mean to you, the patient? What does this mean to you, the husband? And helping them put it together. So palliative care can happen at any time during a disease. In the beginning of a disease, when you're working on curative treatment, on surgery, on radiation, on chemo, palliative care may have a smaller part in the whole disease process. As you get closer to the end of life and there's not so many cures left, you've done all your chemo, you've done all your surgery, you've done your radiation, and now your condition is terminal, palliative care takes a larger role in that disease process. So palliative care is something that we can do while you're still seeking curative treatment at any time during your disease trajectory, and that's really what palliative care is. Hospice, on the other hand, is something that was designed to be a Medicare benefit. Medicare created this, I don't know, I think maybe 40 years ago, looking at a way to give people care at the end of life. Hospice is generally for people that have a terminal illness with less than 6 months to live, which is a problem because doctors often don't want to say there's only 6 months, so people don't end up going on hospice really until there's only days or weeks left. I mean, how many of us know somebody who went on hospice and died a week later? Really, that patient should have been put on hospice 6 months earlier. But again, we're back to the fact that people don't want to talk about it, so people don't ask their doctor about it. Doctors don't bring it up because they don't want people to feel that they're giving up on them, and therefore you end up with hospice in the end. You know, the average length of stay on hospice is 28 days. It's supposed to be a 6-month benefit. But in reality, we're seeing people only on hospice for 28 days. Hospice is an interdisciplinary approach to care. They have a nutritionist, a social worker, a dietitian, a nurse's aide, a nurse, a chaplain. All of these interdisciplinary team that comes to a family. It can occur anywhere. It can occur in your home. It can occur in a nursing home, in an assisted living. There are some hospice facilities in our area where you can actually go and live there. So hospice is more a benefit when you're in the last 6 months of life, but that doesn't mean that if you don't die in 6 months, you're not eligible anymore. After 6 months, you're reevaluated. If you're still declining, if you're still meeting criteria for hospice, then they continue you and extend you. And they can extend you up to, there are some people that are on hospice a year or 2 years because they're just declining slowly. So for all those people that think, I'm not ready for hospice because I'm not dying soon, there's so many things that hospice can give you, so many benefits, so much support, having another set of eyes there for you, another person to talk to, and all of those good things that you can get from hospice. You know, you shouldn't wait until the last week. There's benefits in the last 6 months to a year of life. The problem is we have to talk about it.
Well, you're both outstanding advocates and explainers of the situation and what benefits are there for people with terminal illnesses. But I want to get back to palliative care. Is palliative care a department? Is it a person? Is it somebody that you call? I mean, because what you've explained is what everybody would want to have, is somebody to oversee and supervise the multiple disciplines involved in the caring process. So who would you call? How would you call that person? Do you go to your hospital and say to your doctor, I want a palliative care expert?
Many more hospitals are having palliative care teams at Overlook Hospital. We have Dr. Gregory and Dr. Jean Kerwin head up the team at Overlook Hospital. There's a palliative team there. Morristown Hospital has a palliative care team headed up by Dr. Knops. So when you're in the hospital, you can ask to see the palliative care team. The problem is that people are in such emotional distress when they're in the hospital that they don't think to ask, and sometimes it's not offered. Which is why we're doing this show, to get people more educated in what really it is and what they should be asking for.
Okay, very good. Yes,
Karen.
May
I interject?
Yes.
And this is a very important point. Atlantic Health System prides itself on nursing empowerment. And frequently, the nurse at the bedside caring for someone, as well as their family members, will suggest a palliative care consult. It is the philosophy of the hospital to treat every person with dignity and respect while addressing all of their health care issues. So I think that's really important for people to understand, that should you forget to ask for a palliative care consult, that will most likely be brought up by the person caring for your family member.
Okay, and you're right. This program is here to inform everybody that it exists, it's there, and what its purpose is. Because as we see, families as well as the patients are really struggling at this point. And you mentioned fears, you mentioned concerns and anxiety. So let's repeat what some of the acknowledged concerns are. I mean, and so what is one of the most important or the most primary issues that a patient and their family will manifest to you?
The biggest fear that I see is families, as well as people at the end of life, are concerned about becoming addicted to the medication that gives them comfort. And this is a very falsehood, because they're at the end of their lives. They will not become addicted. They are probably not addictive personalities, and there is no reason for these people to die in pain.
And that's the second fear, is that people are going to die in pain.
Physical pain.
Physical pain. So our job is to keep them. What we want to try to get families to understand is that our goal is that in the time you have left, you have the best quality of life that you can. If you're in pain, you can't have quality. Your child can't come up and jump on the bed. You can't have your dog, sitting on your lap if you're having pain. If you're pain-free, you can have better quality. So